a first trimester scan. Right. So first and foremost, why is this scan needed? There are a couple of very important things. One is dating, which is going to be very important. So what happens is, as we progress in our, through the pregnancy, the ultrasound estimation of the EDD is going to become more and more erroneous, right? The dating is going to go more and more haywire. So it is this early scan which is absolutely essential to establish the dating. And once this dating is established, it is then, that we do the follow-up scans, keeping this in mind, right? So when we do the anomaly scan or we do the obstetric Doppler, this dating scan is very, very essential, right? We also need to know the chorionicity and the amniosity if this is not done already. Now, ideally, when we do a scan in an early, pregnancy at say 7 weeks or 8 weeks or whatever, at that time itself, establishing the chorionicity and amniosity is very, very important. If that is not done, then you should do it at the NT scan because when you look at monochorionic twins, monochorionic sets, or looking at the number of IVFs that we encounter today, all sorts of permutations or combinations are possible. We look at 4 embryos, 5 embryos, three in a sac, two in a sac, all sorts of different things. So knowing this chorionicity and amnioticity is very important because monochorionic twins are going to behave in a very different fashion. You have to follow them in a different fashion. And that is why you need to establish this properly. And again, as you progress through the pregnancy, this becomes more and more challenging, right, to establish the chorionicity and the amnionicity. Now, we have to, of course, screen them for chromosomal anomalies. That is, of course, the crux of doing the 11 to 14 week scan. But we also have to scan them for major congenital anomalies. Now, looking at the kind of machines that we've been using, looking at the kind of transducers we've been using, we are able to see a lot of structural details even at this stage. A good number of things we can identify at this stage. So it is very important that we look at these structures. And again, we'll be going over it. And the other important thing is also screening these patients for preeclampsia. Okay, and we'll see how we do that. But again, identifying this subset of patients is very, very important, especially in a country like India, where this can be kind of easily taken care of, and we don't want to burden the healthcare system, and we don't want those late trimester losses at a later stage, right? So this is basically the reasons why we need to do a good scan at 11 to 14 weeks. So once we know what we have to do, let's keep a protocol in mind. So we have to, of course, look at the number of feti. We have to look at the viability. We'll be looking at the fetal heart rate. We get an overall assessment of the fetal environment, the fetal movements. We need to do some biometry. We need to, of course, screen them for any aneuploidies. And like I said, also, of course, do a structural scan as well. So coming to the number, now, like I mentioned before, we are due to the number of IVFs, we are increasingly seeing these monochorionic pregnancies. Sometimes you have 3 pregnancies, sometimes you have 4 pregnancies, but you need to identify this membrane properly, right? So you need to see where the membrane is thick, where the membrane is thin. In case there are multiple feti, which of these are within a single sac? This is also important because nowadays we do fetal reductions at this stage, right? And the earlier we do it, the better. So this is the ideal stage for us to do fetal reductions. So prior to doing fetal reductions also, we need to have an assessment of what chorionicity we are looking at. We need to have an assessment of the feti. Is any of them abnormal? And if any of them is abnormal, we can go ahead and do a reduction for that particular fetus, right? So knowing the chorionicity is again very, very important, like I mentioned before. And monochorionic twins typically present a problem because they can have a lot of complications later on in the pregnancy. You can have twin transfusions, you can have selective growth retardations, you can have anemia polycythemia sequence. All sorts of complications can potentially come up in monochorionic twins, and managing them actually becomes quite challenging later on in your in as the pregnancy advances, right? So, of course, the essence of identifying the monochorionic twins is that you see that there is either a thin membrane or no membrane between the two feti. If you do see a thick membrane, you know that, okay, you're looking at a different subset. And these are all, like, I mentioned all sorts of permutation combinations that can come up with. You can have quadriamniotic quadruplets and all sorts of permutation combinations. So again, Knowing this at this stage is very, very important. Now, once you've done that, we need to establish the gestational age for the fetus. And at this stage, there's only one measurement that we need to really take for establishing the gestational age, and that is your crown rump length, right? So this is the crown rump length, which we take in a maximum straight line. Now, the crown run length not only provides a basis for your future scan, it may at times even give you subtle clues as to what is already happening. For example, if you have fetuses which are affected with trisomy 13 or 18 or maybe Turner syndrome, you may already see a growth restriction as compared to the early scan, right? So you go into the scan thinking of a fetus which is going to be, say, 14 weeks, but you're looking at something like a 12-week fetus, you know that, okay, something may be wrong over here, right? So again, an important point to note down. Now, the moment we look at the CRL, the next thing, of course, our cursor goes on to the fetal heart. And normally at this stage, we look at a fetal heart rate of, say, about 150 beats or so, and it can potentially decrease in trisomy 18 and it can potentially increase in trisomy 13. So it's not that all feti with abnormal heartbeat will have some chromosomal disorder, but again, it provides you a clue that, okay, something may be going haywire over here. Now, one thing which, we should actually always look at is the general fetal environment. And what I mean by this is, just have a look, is the amniotic fluid looking adequate? Now, we may not have measurements for the amniotic fluid, but generally we look at the maximum vertical pocket. We look if the fetus is healthy, we look if the fetus is jumping around. Normally at this stage, we'll see like this kind of a fetus, just jumping around, moving the limbs. So you know that, okay, all in all, it looks to be a hunky-dory fetus, right? So just it gives you kind of a rough assessment as to what is happening. Then, of course, you want to have a look at the placenta as well. You want to have a look at the cervix as well. Placental migration is known to occur, so it's not, so don't get too panicked if you see a low-lying placenta at this stage. You may see these placenta covering the os at times, but a good number of them do end up moving up over a period of time. But again, you do want to look at the cervix as well. If the cervix is too short, they may want to intervene. And the best way to actually look at the cervix is doing a transvaginal scan. So whenever you want to get a good cervical length, you are asked for a good cervical length, specifically asked for a cervical length, then we should do a transvaginal scan. Now, coming to the point of detecting aneuploidies. Yes, of course, the reason that we want to do, and one of the crux of doing these scans is identifying the odd fetus out, right? We want to try and identify the fetus with aneuploidy. So what do you do for that? Now, traditionally, this was started, the screening started with maternal age. Those who were above, say, 35, 40 years had increased chance of having an MLS baby. Then we moved on to triple markers, we moved on to dual markers, and then, of course, the USG, right? But currently, the best things that we have available is the dual markers. Of course, we have the maternal age that acts as a screening marker straight away. We look at the dual markers and we look at the ultrasound, right? So this is something that should be done for practically all pregnancies. Okay, so let's look at this in a little more detail. Now we know that the crux of doing the nuchal lucency scan is, of course, looking at the nuchal translucency. But before we go on to measuring the nuchal translucency and putting it down in your report, you have to make sure that these markers, whether it's nuchal lucency or nasal bone or whatever, we have to do with adequate training. We should be knowing exactly what we are looking at. We should be using high-end machines. Sometimes it's very difficult to identify these nasal bones, and looking at the, nucleolucencies on those portable or very suboptimal machines. So that is something that we need to take care of. And of course, we have to adhere to the established protocols. So luckily, we have protocols by FMF, we have protocols by ISUG, and it's best that we adhere to this because it gives you a good standardized way of how to look at things. And of course, this is, so that you don't try and miss out on things and identify as many problems as you can. Now, so why this nuchal lucency, right? So It was in 1866 that Sir Langdon Down noted that these patients with trisomy 21 have skin elasticity just behind the neck, right? They have a very elastic skin, and the skin is typically large for age. And this was put into an ultrasound perspective. So in the 1990s, it was a nuchal thickness, which was, or the rather the nuchal fold, which was, laid a lot of stress on, especially in the second trimester. And this moved on to what we call as the nuchal translucency in the first trimester. And yes, it is a fairly effective way of identifying feti for trisomy 21. So, what is nucleolucency? On ultrasound, what we want to identify is this hypoechoic area or a collection of fluid which is under the skin behind the neck, right? And again, when we talk of nucleolucency, we are typically referring to patients in the first trimester of the pregnancy. And there is a very, very specific time when we should be doing it. So this is between 11 and 13 weeks plus 6 days. So rather than concentrating more in terms of the weeks, we generally concentrate on the CRL. So when we look at these feti, when we want to do the nucleolucency scan, we have to get a CRL between 44 millimeters and 84 millimeters, right? So that is absolutely essential. And that is your first rule that you have to lay down. Okay, so once you have identified this fetus and said that, yes, this is a fetus where I can do a nucleolucency scan, we move on to the next stage. And the next thing that you need to get is a good sagittal image. Of course, you have done the CRL, like I mentioned already before. Now you want to get a good magnified image of the nucleolucency. So for that, what you should do is magnify this image so that you are able to see the fetal head and the fetal thorax, which is occupying, say, about 75 to 80% of your screen. The fetus should ideally be in a neutral position, right? So you do not want a fetus which is flexed, with a head flexed or hyperextended. You do not want that kind of fetus. And the second thing that you need to be very, very, very careful about is not to mistake the fetal skin for the amnion. Okay, so this is the fetal skin, what we are seeing over here. And sometimes what happens is, especially, like in this particular frame, the fetus is very close to the uterus, so you're not able to see the amnion too well. But if the fetus, there's a little bit of gap between the uterus and the fetus, you'll actually see this membrane continuing, and you may mistake it for a nucleolucency. So you have to be very careful. Do not mistake this amnion for the nucleolucency, right? So I already said that the magnification should be large enough so the fetal head and thorax is occupying 75-80% of the screen. And then another criteria that has been proposed is that the magnification should be so much that each movement, of the caliper produces only a zero 0.1 millimeter change in the measurement, right? So once you put in all these criteria, you get an appropriate image. Then you identify this hypoechoic area, which is behind the neck, right? And you can take multiple measurements. And normally what we do is we take the highest measurement that we have seen. So during a scan, suppose I take, say, 3, 4, 5 measurements, right? It's the maximum measurement that I want to record, and that is what I will report. The other important thing is when you place these calipers, you have to place the caliper on the line, right? So it should not be within the hypoechoic area, it should not be within the hyperechoic area, it should not be within the fluid. The caliper should be placed exactly on the echogenic lines, right? So that gives you your nucleolucency. Now, the next question always is, what is the normal nucleolucency? So when we talk of a normal nuchal translucency or nucleolucency, as we talk about it, we are talking actually in terms of percentile, right? And when we talk of maximum nucleolucency. So for a CRL corresponding of about 45 millimeters, the median value is about 1.2 and the 90th percentile is about 2.1. For an 84 millimeter CRL, this 95th percentile corresponds to 2.7 millimeters, right? So do not go by any dictum that, okay, 3 millimeters is definitely abnormal, 3.5 millimeters is definitely abnormal. Yes, it tends to be abnormal because once you start looking at these measurements, they're of course above the 95th percentile. but you have to be very, very careful and you have to measure it, right? So how do you measure it? How do you measure the percentile? It's actually very easy. All you have to do is go online, look at this perinatology chart, right? Here, this is absolutely freely available online. So you enter your CRL, you enter your nucleolucency, and the moment you press this, you get your percentile of the nucleolucency, right? And you can straight away, maybe attach this to your report page as well, or take a printout for your reference, whatever. But this straight away gives you the percentile, and all that you're looking at is this nucleolucency at 95th percentile or above? If so, then yes, this is definitely going to be abnormal. So why does nucleolucency increase? It can be because of the failure of lymphatic drainage. It can be because of cardiac defects. It can be because of venous congestion, the head and neck. There can be altered composition of the extracellular matrix. There can be fetal anemia, hypoproteinemia, fetal infection, and multiple reasons are there, right? But like I said, all we want to identify is the nucleolucency thickened. Now, like I said, we discussed previously, the major component of this is to try and identify our Down's syndrome feti affected with Down syndrome. And as you can see on this chart, the more is the leucolucency, of course, there's a higher chance of there being a chromosomal defect. But from a very practical perspective, once we see anything more than 95th percentile, we have to be alarmed. We know that something is going haywire over here, right? And if it does happen, you do see a nucleolucency above that, then you need to do an invasive procedure. Ideally, we do a CVS at this stage. So somewhere between 12 and 14 weeks, we try and do a CVS. Then if that is not possible, then maybe after 16 or 16 and a half weeks, we do an amniocentesis. But once you see a nucleolucency which is thickened, doing an invasive procedure, getting the chromosomal analysis is absolutely important. And it is not just trisomy 21, where you can see the increase in nucleolucency. You can see this in Turner syndrome. You can see this in trisomy 18, 13, right? So it is not just trisomy 21 you're looking at. Once it's abnormal, you can have these multiple potential problems. But what happens if the karyotype is normal, right? So you see a nucleolucency, but the karyotype is normal, like you are seeing in this case. What do you do? So wait, there are a lot of other conditions in which you can have, associated problems. So the nucleolucency can be increased with cardiac abnormalities, congenital diaphragmatic hernias, skeletal dysplasias, any renal issues, high drops, Noonan syndrome. Now, Noonan syndrome is not something that can reflect on your routine karyotype, right? So you may have to store the DNA, you may have to evaluate this for Noonan syndrome, and there's a whole bunch of things that potentially can happen. Also, if you just see an increased nucleolucency, you're not able to identify any structural or chromosomal defect, there is a higher chance of miscarriage in this feti as well. And remember, I spoke about the TTTS. When you're looking, what we're worried about is a TTTS in monochorionic twins. When we do see a discrepancy in the CRL, or we see a thickened leukolucency at this stage in one of the feti, it can potentially point to an early manifestation of TTTS, right? So basically, it can be high because of multiple problems. Now, one more thing that you need to keep in mind is that once you have identified that the nucleolucency is increased, you have to put this fetus through a evaluation pathway. There's a very high chance that the nucleolucency may regress after 14 weeks, but this can happen in spite of a chromosomal abnormality being there, right? In spite of a structural abnormality being there, which you may not be able to detect at this earlier stage, right? So once you have identified a problem, you know that, okay, this fetus has to be evaluated. Don't let it go, right? So sometimes it so happens that, we have patients who come in at 12 weeks with increased leukolucency. Then they come back again at 15 weeks and we see that, okay, leukolucency has regressed. Then they said, okay, now that it's regressed and everything is normal. No, it doesn't work that way. You have to evaluate these patients further, right? So again, this is very, very important. So how do we evaluate these patients? Now, like I mentioned, if you have a leukolucency more than 95th percentile, you straight away do an invasive procedure, which is a chorion villus sampling, which is done at this stage, When you do the chorion villus sampling, ideally we at least send the samples for a QF-PCR and a karyotype. So karyotype gives you a detailed analysis of the chromosome. So it gives you a problem. If you know, it will help you to detect if there are any chromosomal abnormalities. But you can also do something called as a microarray, which will give you a more detailed analysis of the chromosome. You can pick up some micro deletions or so. What we also typically do is store the DNA and keep, right? So once the sample is taken from the placenta in the chorionic villus sampling, we store some of the DNA, we as in the lab, and if required, you want to evaluate this patient for a Noonan's or something later on, you have that ability to do as well, right? So once, of course, like I said, you do a genetic evaluation for this fetus. If the genetic evaluation does not rule out anything significant, then of course, we will at the same time do a detailed scan when we do a NT scan, but you have to subject this patient to a little more closer scan, right? So normally we do an anomaly scan somewhere around say 18 or 20 or 21 weeks, but we do not wait for that long for these feti to look at the scan. We try and evaluate them at an earlier stage, maybe around 15, 16 weeks, and try to identify if there is any problem, right? So if the nucleolucency is still persistent, there may be a possibility of some infection or some syndrome. So you have to counsel the patient accordingly. And like we mentioned before, there can be a risk of spontaneous abortion as well, right? So all this has to be conveyed to the patients, right? And if everything is normal, then yes, you can, with a little bit of caution, tell the patient that, okay, everything is going to be fine, and we'll come about how we counsel the patient a little later. Now, nuchal lucency is not the only first trimester marker that we look at. We also look at other things, which is typically the nasal bone. So when we want to identify the nasal bone, what we try to look at is these three echogenic lines. So you have the nasal bone, you have the skin, and this is the tip of the skin. So you see these two lines and one dot. That is what you want to definitely identify. If you do not see this echogenic line, you do not see this bone, this qualifies as absent. Or if you want to, if you want a better terminology, you can say this is a non-ossified nasal bone, right? So this is again something that we always, of course, keep a tab on. Now, one of the questions which always comes up is, do you measure the nasal bone at this stage? It is not really necessary to measure it at this stage. Even if you identify the nasal bone and you're confident about saying that, yes, the nasal bone is there, it is absolutely good enough, right? Facial angle is, yes, theoretically you can do it, but it is not something that we end up doing practically. Yes, if we do see something, grossly going abnormal, then we will maybe go and measure the facial angles at this stage. The other important thing which is there is looking at the ductus venosus, right? So ductus venosus is shunts basically a portion of the left umbilical vein, blood flow directly to the IVC, allowing oxygenated blood from the placenta to bypass the liver, right? So what this does is you see this as an area of aliasing, right? So if you follow this umbilical vein, what you are able to identify is this area. If you can see this on the image, there's a little bit of aliasing happening over here. The sagittal way is the easiest way to identify it, but you can identify it in actual as well. And if you put your pulse Doppler over here, this is the very, very classical waveform of the ductus venosus that we end up seeing, right? So we are looking at three waves over here. You're looking at the S wave, the D wave, and then we have the A wave, which is this depression over here. Now, normally, all these waves are above the baseline, and that is very important when you want to keep that, when you want to look at a ductus venosus, right? So the moment you have an abnormal ductus venosus, what happens is this A wave starts dipping, right? And what you see, what is the abnormal ductus venosus is when you have this reversal of A wave, right? So this again is associated with increased chance of chromosomal abnormalities, increased chance of cardiac defects, and at times even fetal death at a later stage, right? But it is not a only marker. So about 80% of cases with reverse A wave in pregnancy, the outcome may be normal if you identify it at this stage. But what it points out again is again that you need to be cautious. This may be a chromosomal abnormality. There may be a cardiac anomaly. So always keep your eyes open for things, right? At times, you may not be able to identify the ductus venosus at this stage. So don't hurry up into calling this as an absent ductus venosus. You should follow these feti up at 16 weeks, maybe 18 weeks. A good number of times you are able to find a small ductus venosus. If not, then again, we have to think of a whole lot of other spectrum of problems, including venous anomalies or maybe chromosomal anomalies as well. The other thing that we look at is the tricuspid regurgitation. So we place our cursor in the tricuspid valve and we look at this waveform. So what we want to identify is this regurg component, right? So if this regurgitation is lasting for approximately half the systole and with a velocity of more than 60 centimeters per second, then we can say that yes, there is tricuspid regurgitation. And again, this can be due to a possible chromosomal defect or even an abnormal heart, right? So a cardiac defect in the fetus. Okay. Uh, like I said, nowadays the transducers are so good, our machines are so good, we are able to identify even things like aberrant subclavian artery in the first trimester. So always keep a watch out for that. And if you do identify it, then again, yes, there's a chance of a chromosomal anomaly. So all of these are markers which are going to hint towards the presence of a chromosomal anomaly. Megacystis is relatively easier to identify. You will get a distended bladder, and we'll have a look at this a little later again. Single umbilical artery is, yes, it is a marker, but you have to be very, very careful when you label something like a single umbilical artery at this stage. Okay, a good number of times, you're not able to identify it too well. The other umbilical arteries may be small. You're not seeing it too well. So what do? You try and look at this, and with a linear probe, you try and do a transvaginal scan. I mean, if you ask me, it's only when I do not see this on a transvaginal scan very convincingly, then I will say that yes, there is a single umbilical artery. And again, talipes deformity is something that we need to be careful about in the first trimester, because at times you can get an intermittent deformity of the foot, and that's not really a talipes. So you have to be a little cautious when you label a talipes deformity. You have to be very sure that it is persistently there. You can encounter diaphragmatic hernias as well. We'll go over this a little later, and there's a high association with trisomy 18. So what this does is, all these markers, they give you some clue that, okay, there is a chance that something is potentially abnormal, and you will put this fetus through a further testing. Now, remember what I told you, it is not just the NT scan that we do. There are a couple of other tests that we do as well, right? And what has been very popular for quite some time is doing the dual markers. Now, mind you, there's a lot of confusion at times between should we do a dual marker, should we do a triple marker, and triple sounds more attractive because, it sounds like there are three markers, but no, it is actually redundant. What we do now is the dual markers. So at the most, you have to do a dual marker with your NT scan, right? And again, if you do see a high risk in your dual markers, you will want to do a genetic testing for this baby, right? So typically the marker comes, the report comes with this risk. So if you get a cutoff, which is say more than 1 in 250, then that indicates a high risk for trisomy 21. If the risk is more than 1 in 100, it indicates a high risk for trisomy 13 and 18, right? So a report will give a calculated risk, right? So for example, over here, the calculated risk for trisomy 21 is above the cutoff, which represents an increased risk. And what is the risk over here? It is 1 in 50, right? So anything more than 1 in 250, or rather less than 1 in 250, sorry, should be considered as a high risk. At the same time, in the same patient, the calculated risk for trisomy 13 or 18 is 1 in 3077, which indicates a low risk. So looking at this report alone, it would indicate that there is a high risk for trisomy 21, right? And this, of course, is proven on your karyotype. Now, Remember, I told you that we have different ways of screening, but over the period of time, what we have realized is this is what works best. You of course have a look at the maternal age. You look at the free beta HCG and the Papa A, which is the dual markers, and you combine this with a nuclear translucency and a nasal bone scan. And with this, your detection rate is almost 97%, and with a false positive rate of just about 5%. So this is what works best in terms of screening. And nowadays, what we typically do is when we have a patient, we actually do the NT scan of the patient. We then subject this patient to a dual marker. So when this patient goes in for the dual marker, the NT is already there, the nasal bone is already documented, the CRL is already documented, and we can actually get a combined risk involving the ultrasound markers and the dual markers, right? So this, of course, gives the more comprehensive report. And of course, again, if this risk is going to be high, we will subject this patient for a genetic testing. Right. So when you have a patient, like I said, with something like a cystic hygroma with a TOF, there's a high chance of chromosomal abnormality. You do a FISH, you do a microarray as far as possible, and you may end up detecting some problems. So what these first trimester screens have done, okay, what this combined screening has actually done is reduced the invasive testing, right? So it is not just that if you're the dual markers are altered, you'll do a genetic testing. If there's a minor marker on the ultrasound, you do a genetic testing. No, you combine the whole thing, and this will help you to reduce your invasive testing. So if you look at these numbers have gone down from 20% to 3%, and at the same time we are able to detect more and more chromosomal disorders, right? So that is basically how we can impact the patient in the first trimester. Now, remember I told you at times it can happen that, the nucleolucency is altered, you have evaluated everything, but nothing is coming up, right? So what do you do? So of course, first and foremost, you do a genetic testing for this patient. You keep in mind that even if you're not seeing any structural defect at this stage, it may come up later. So you always have to tell the patient this thing, right? But if you do have isolated NT, you're not able to detect anything, you have to counsel the patient very properly. And this is something that we find very, very useful while counseling. So if you look at, about 100 fetus with a thickened nucleolucency, about 20% of them have a chromosomal abnormality, right? So 80% of them will be normal. Of this 80, about 10 of them may have a structural defect, which may be detected at the NT scan or may be seen a little bit later. So 70 will essentially be normal. And then about say 2.5 of these would die in subsequent weeks without any specific cause, right? So what this means is if you have seen a patient with or fetus with an increased nucleolucency, you have done all possible testing and everything is normal. Even after following this patient up and say at a 18-20 week scan, you've done your anomaly, you've looked at the heart properly, there's a 67% chance that these feta are going to be normal, right? So they may not come up with anything. 67% of them may be normal. And this is very important in terms of counseling to the patient. Now, another thing which has come up over the last few years, and has become increasingly popular is what is called as the NIPT or non-invasive prenatal testing. Now, what this does is it kind of replaces the dual marker and it has far better sensitivity than the dual marker, right? So what you do over here is again simply draw blood from the patient's hand, right? The maternal blood. From this maternal blood, there is, this fetal cells, the cell-free DNA, which are coming off the placenta of the fetus. They are isolated, right? And they are subjected to these genetic testings. Now, the advantage of this is that it detects the common trisomy problems with a very good sensitivity. So if you look at this, sensitivity is 99% plus. right? Even if you look at sex chromosome abnormalities, you're looking at 90% plus detection rates. It can look at all chromosomes with fairly high sensitivity, and it also looks at some of the common micro deletions. So if you're suspecting things like DJOT syndrome, you can go ahead with the NIPT and you can get your answer. So again, this can help you to reduce your invasive testing, right? And one of the things which you always have to keep in mind over here is you should look at the fetal fraction. So ideally, you should have a fetal fraction which is say about 10-12%. That generally gives good answers. The other advantage of doing this is, unlike say a dual markers, which you can do only at a restricted time period, this is not so restricted. You can actually do the NIPT anywhere after say 10 or 11 weeks, and it gives equally good results. Right. So the only disadvantage right now is the cost, which is also, coming down as we talk. And so hopefully this should be available more as a screening tool. So potentially this can replace not only your dual markers. There's talk of this replacing ultrasound as well, but I don't know. I'm a little hesitant to say that. But yes, it can definitely replace your dual markers and with much more sensitivity. Okay, so again, this is just to show you some of the detection rates for, especially when it comes to trisomy 21. You have more than 99% detection rate for NIPT, which is very, very good. Now, the other big advantage of NIPT is that it works decently well in multiple gestations as well, right? So in fact, monochorionic twins, it is as accurate as your singleton twins, right? Because basically you're looking at a single placenta. When you are looking at dichorionic twins, it is a little less accurate, but still it is more than about 94-95%, which is ideally very, very good. But if you have multifetal pregnancies, then yes, it does become a little bit of a challenge. Now, the other important thing that we need to do at this stage is also screen these patients for preeclampsia, right? So what we do for that, we look at the uterine artery Doppler, we look at the mean arterial pressure, and we look at the serum biochemistry, right? And what we look at in the serum biochemistry is this Papa A and also something called as a PLGF, right? And once we combine these, right? So you have the biophysical markers, you have the biochemical markers. We can actually come up with a kind of a combined cutoff like we did for the risk of Down syndrome. And where on ultrasound do we play a very important role over here is looking or measuring the uterine artery, right? So the uterine artery is actually quite easy to identify. You look at the sagittal section of the cervix and slightly tilt towards the left and the right, and you should be able to see the uterine arteries very, very well. And so they are somewhere at the level of the internal os. Again, there are a lot of guidelines as to how you should take it. So you should have a sampling gate of 2 millimeters to cover the whole vessel. Angle of inclination should be less than 30. Peak systolic velocity should be ideally more than 60. But anyway, what we are basically trying to measure over here is the mean uterine artery PI, right? So which is basically the average of the right and the left, right? So whenever we look at uterine arteries, look at the right, look at the left, and then give a mean measurement. And whenever this measurement is more than 2.3, then we can potentially, raise our alarms over here. There is a chance of this patient going into a preeclampsia at a later stage, right? And why this is important is if you detect this at this stage, right, at an early stage, all these patients are done is put on ecosprin or aspirin, and majority of them do well, right? So you're preventing all these late, third trimester complications by just a simple aspirin, which is again very, very inexpensive. And you can actually play a very good role over here, right? And like I mentioned before, what you do is you look at your, you give a comprehensive report. So you look at your beta Papa A, you look at your beta HCG, you look at your PLGF, you look at the mean arterial pressure, you look at the mean PI, right? And you can actually give a combined report. So you can predict the risk of trisomies, you can predict the risk of preeclampsia, right? So anything more than 1 in 100 is again high risk for preeclampsia. So you can give this kind of a comprehensive report, right? So you're looking at the structures, you're looking at the nasal bone, nucleolucency, trying to identify the risk of trisomies, trying to identify risk of preeclampsia, and a whole bunch of things, right? So this is what we should be doing during our NT scans. And now I'll quickly go over the structural scan because there's a lot that can be actually done over here. I won't have time to discuss this in too much of detail, but I want to show you something towards the end. So again, we have some ISUG practice guidelines as to how we can do our structural scan. So like I said, I'm not going to go too much into the detail. But one thing that I would like to pinpoint over here is, especially as far as the structural scans are concerned, your high resolution probes, your transvaginal scans play a very, very important role. So good number of times you're not able to see these structures with your, routine curvilinear probes. But the moment you do a TV or you use your transvaginal scan, I'm sorry, you use your high frequency scan, you're actually able to see a whole bunch of things, right? So in the CNS, we always try to look at the cranial bones. Obviously, we make sure that the choroid plexus is filled with the ventricles. You can see that the falx is in the midline. Yes, this one thing I definitely do want to stress upon a little bit. So very important thing is we try and look at something called as an intracranial translucency, right? So if you look at the sagittal section of the fetus, you have what is the brainstem over here. You have another lucency in the bottom over here, which is the cisterna magna. And in between, what you have is the nuchal intracranial translucency, right? So this is again very important. Why? We'll see a little later, especially if this is obliterated, there's a high chance of there being a neural tube defect, right? So we also look at the posterior fossa, the same structures. We try to look at it in an action view as well. So again, we are able to see the brainstem, the IT, the cisterna magna. We can actually see the choroid plexus as well. And as far as the anomalies are concerned, yes, we can identify a whole bunch of them. You have no skull bones, you're looking at a acrania exencephaly sequence. If you have a hyperflexed head like this, you're potentially looking at iniencephaly. You can identify meningoceles, encephaloceles, even things like holoprosencephaly can be identified in the first trimester quite easily, right? So all you have to do is actually look at your, these feti with a high frequency or transvaginal probe. And again, there are a lot of stress which has been laid on identifying your neural tube defects, right? And there are intracranial signs of neural tube defects which can be identified in the first trimester itself. So what you see is something like a dry brain. So you see that the choroid is the brain is completely filled with the choroid. There's no fluid, absolutely. There's no, the ventricles are kind of obliterated. If you look at the BPD or by HC, it is less than 10 percentile. You may end up seeing something like an obliterated cisterna magna or parallel cerebral peduncles. All of these are going to give you clues to the absence of to the presence of a neural tube defect. And like I mentioned before, what you can see is the obliterated IT. So what you're seeing over here is only the brainstem and the cisterna magna. The intracranial translucency is completely obliterated. This is a very, very big clue towards the presence of a neural tube defect. And then, of course, once one person describes something, we are going to come up with more things. So there'll be more measurements to do and more ratios to take. This is one of the things, the brainstem to brainstem occipital bone ratio. If this is more than one, then again, it indicates nucleolucency. But at times you can even have an increased intracranial translucency. And when does that happen? That typically happens when you have a posterior fossa malformation, like something like a dandy walker. So again, you may not be able to identify and pinpoint this at the early stage, but you follow these patients up and you will end up picking up something like this. At times, the increased IT can also be a marker of chromosomal abnormalities. As far as the spine is concerned, yes, what we are trying to identify is the neural tube defect. So you see this arch, this become like a V shape of the arch. You can see something, some soft tissue sticking out over here. But again, what really helps over here, and I'm making this point again and again, is try and look at them with high frequency or your transvaginal probes. You'll actually be able to identify a whole bunch of things, right? You can identify subtle things like kyphoscoliosis, or like in this case, this was a sacrococcygeal teratoma. Now, when you think of face, right? This is not something that really hits you when you think of doing this in the first trimester, but there are actually, things you can see. You can identify the orbits, you can identify the what we call as the retronasal triangle, you can identify the nose and lips. The nose and lips, yes, they can be quite challenging at times, but we try and make an attempt to look at all these structures. So another very important landmark that we always make sure that we look in the face is what is called as the retronasal triangle. So in the retronasal triangle, what you have over here is your frontal process of the maxilla. You have the nasal bones which are coming up at the top over here, and then you have the primary palate which is coming up over here, and the mandible over here. So once you see this, it kind of rules out a palatal defect, right? So another thing which can be used to identify the palatal defect is this maxillary gap sign. So in a sagittal view, you should normally see a nice maxilla, but if you do identify this kind of a gap, you are potentially looking at a maxillary defect, right? So this is another case where you can see that this defect is seen in the RNT, or the retronasal triangle view, and you can see this defect coming up over here. And of course, when we saw this properly, there was actually a cleft lip also which was identified, right? So yes, cleft lip and cleft palate can be identified in the first trimester. You at times have to be a little cautious, but it can, of course, you follow these patients up more closely and you may be able to identify these defects a little bit earlier. And one thing that you always need to keep in mind is the moment you see multiple anomalies, right? So for example, over here, you're just about seeing a nasal bone. Yes, you still can't call it abnormal. But if you look at the jaw, there is some retrognathia which is sitting up over here. The ventricles are a little bit dilated. You're seeing a potential cleft lip and cleft palate over here, and even something like a syndactyly. So the moment you see these multiple anomalies, you should keep in mind there's a good chance that there's going to be a chromosomal abnormality, and you evaluate the fetus accordingly. And now coming to the fetal chest, what we want to identify is the situs. Make sure that there's no situs abnormality. So make sure that the heart and the stomach are on the left side. If the lung fields are symmetrical, there's no effusion or masses coming up anywhere. And the sweeps really help. So always, get in the habit of doing sweeps over here. A diaphragmatic hernia, like I told you, can be a manifestation of trisomy 13, and sorry, trisomy 18. 13 too as well actually at times, but so always keep watch out for that. You can see how nicely the funding bubble is sitting up in the chest next to the heart over here. Fairly easy to identify, especially if you do a transvaginal scan. Sorry. The other thing that we always make sure we look at is the heart. And there are some things that we need to look at. One is, of course, we look at a regular cardiac activity, but we try to look at least a basic four-chamber view. So we try to ensure that there are at least the four ventricles, the four chambers of the heart are seen well. They're filling up well. The color is in the same direction. And we can also look at these 3VT view, right? So four-chamber view and the 3VT view is something that we should always get into a habit of looking at this stage, right? So we can identify chamber discrepancies. Sorry, this 3VT view is what looks like this. So you have the ductal arch and the aortic arch, the four-chamber, of course, in this fashion. You can see the colors filling up in the same direction. So in the 3VT view, you can see this is the ductal arch and the aortic arch forming this V kind of shape. This is a normal 3VT view. And you can pick up, things like AVSD, hypoplastic left heart very easily. You can even look at arch anomalies, right? And the moment you identify an arch anomaly, the next thing that you need to be thinking of is in terms of a DiGeorge syndrome, right? So arch anomalies, high chance of association with DiGeorge, so you have to evaluate the fetus accordingly. Now, coming to the abdomen, again, I already mentioned that you should look at the stomach in the left upper quadrant, make sure that it's not in the chest, there's no diaphragmatic hernia. We try and make a look at the kidneys and, of course, the bladder as well. Very rarely you can come up things like this where there's like a cystic filling within the neck, and this was actually a esophageal atresia. Renal anomalies can be identified at this stage. If you look at cystic kidneys, they can be little challenging, but again, like I said, if you do a TVS, things do become a little bit better. You can look at the bladder, you can look at the umbilical arteries, quite well with the transvaginal scan. And this was actually a case of suspected Michael-Gruber syndrome, right? And megacystis is when you have a grossly distended bladder by itself, so when it crosses more than 7 millimeters, it's definitely abnormal. By itself, it's a marker of a potential chromosomal anomaly, but at times this can happen because of obstruction as well, right? So you may have something like a bladder outlet obstruction or a megalourethra or something like that, giving rise to an enlarged bladder. We also look at the abdominal wall, make sure that the cord is inserting normally. There are no defects involving the anterior abdominal wall, right? So what we commonly see is something like a omphalocele, where you have a membrane covering the herniated contents. Here you can see the liver and the intestines. And if you see this, there's a good chance that there may be associated chromosomal anomaly. At times you can see something like, just floating a bowel within the fluid, and that is what we term as gastroschisis. Yeah, and then at times you may have something more severe. This is very rare, but it can come up. You can have a limb body wall complex. So you have the abdomen which is not formed properly. The cord is very short. It's almost, the fetus is attached to the placenta, and you can have associated limb defects. So that brings us to the limbs. So when we try to look at the NT scan, we have to make sure that at least all four limbs are seen. All three segments, the proximal mid distal segments are there. And we try and look at the hand and the orientation of the feet to identify any talipus which can be potentially present. But again, like I said, sometimes, in this stage, there can be a little bit of an angulation, intermittent angulation which can come up. So you have to be a little careful before you label this as a talipus or something else. But the other important thing is, whenever you remember, I told you about looking at the fetal environment and see how the fetus is moving around, it also gives you certain clues. So, for example, in arthrogryposis, you may have, contractures at multiple joints, so typically two or more joints. Then you may have fetal akinesia, so there'll be lack of movements. You may not see the flexion extension very well. Again, very important clues as to something that may be going on. And if you see some kind of, weird abnormalities coming up, the bladder is maybe, like a extrophy of the bladder, abdominal wall defects, maybe, some limb defects, spinal defects, and something, where the fetus is just not looking okay, try to watch out for these thin bands, right? So these are amniotic bands, very notorious. They can give rise to multiple defects, multiple structural defects to the fetus, right? And again, depending on the structure involved, it can be, just one limb or multiple structures involved, but you can see this very well during your NT scan. Skeletal dysplasias are, to be honest, not very frequently seen. A good number of them present later on, maybe even in the latter part of the second or the third trimester. And but yes, at times you can potentially identify this. And again, this will be very evident when you look at the limbs. So this is what I want to lay a little bit of focus on. So your take home message from this talk. So number one, we already know that yes, the very effective way of screening these anomalies is, of course, you keep in mind the maternal age, you do your dual markers, and you do your ultrasound. So on your ultrasound, you look at the CRL, you look at the NT, you look at the nasal bone, the ductus venosus, and the tricuspid valve. Very, very important. Wherever possible, and especially what we normally counsel our patients is, if the patient is affording, please go ahead and do a NIPT. That's the only hindrance which is coming up, for doing more and more NIPTs. The moment you have multiple anomalies, if you identify multiple anomalies, there's a high chance of chromosomal disorder being there. So be aware of that. There are some features which are very classical for certain chromosomal abnormalities. I'm not getting into that. But the moment you have a high combined screening, which is high, or if you have an abnormal NT, or even if you just have markers which are high, then you want to subject this patient to a invasive testing, which is typically CVS at this stage. You may want to store the DNA when you do the CVS for evaluating some other things which may be needed later on. And you have to do at least a QFPCR and a karyotype. If possible, do a microarray. Again, the cost over there may be hindrance, but we try to do a microarray as far as possible. If everything is normal, be still treat it cautiously. Follow this fetus a little closely. You may want to evaluate it at 14, 15, 16 weeks. Try and do a detailed scan at an earlier stage. And again, do a detailed anomaly scan. Make sure everything is normal. If everything is looking good, then yes, there's a good 67% chance, almost 70% chance that things are going to be absolutely okay. Do not restrict to only the NT, NB, DV, tricuspid regurgitation. Do a detailed structural scan. You may encounter, everything is not only chromosomal abnormality. Sometimes you may just end up seeing structural defects, like maybe isolated cardiac defects, maybe, isolated diaphragmatic hernia, or maybe something like a neural tube defect, right? Which doesn't have to be chromosomal, right? And this is where NIPT cannot really replace an ultrasound, right? It will not end up detecting something like a neural tube defect or a cardiac anomaly. So doing your NIPT and doing your NT scan is going to be equally important. Always get into the habit of getting good sections, right? One good sagittal section will actually tell you a whole bunch of things. It will give you indirect signs of the NTD. You will be looking at the nasal bone, the nuchal lucency. You may end up picking up things like encephaloceles. I already told you about the intracranial translucency, which is again seen in the sagittal scans. You can pick up spinal defects. You will be able to identify limb anomalies in the parasagittal scans. You can see abdominal wall defects. You can see spinal defects. So this one sagittal scan, getting a good one sagittal section is extremely, extremely important, right? And do not forget to look at the preeclampsia aspect of the patient, because like I mentioned, if you do detect them, if you do identify and segregate these high risk cases at this stage, all they have to do is start an EcoSprint, and a good number of them do fairly well. And another important thing is, the moment you have a patient with an increased nuchal lucency, please counsel the patient. Okay, do not just mention that the nuchal lucency is increased and let the patient go, right? I already showed you what all we can do for the patient, what we can talk to the patient, how, we can give them some numbers, throw some percentages at them. It just makes them a little bit more at ease, right? Yes, it is not the most ideal thing to have a fetus with a thickened NT, but you should try and do something to alleviate the anxiety of that patient. Thank you so much.
Thank you, Rajesh, for that amazing session. We already have a lot of encouraging comments in the chat box. I'm sure there are going to be a lot of questions, as it was the last few times, and I am very novice on taking them. So it will be great if you can just pick and choose
No,
an
no
answer.
problem. No problem. So only thing I don't know is whether what is your time frame like. So anyway,
No,
so
no, you can,
just
we can continue for another 20 minutes. That's okay.
yeah.
Yeah.
Okay.
Thanks, Rajesh.
So no problem. So I think what was the cutoff for the uterine artery? 90th or 95th percentile. So normally what we do is we keep the uterine artery cutoff at about 2.3 and in the first trimester, and we bring this down to 1.4 in the second trimester, right? Another question over here is a thin intertwined membrane with anterior placenta in fetus, and what will be the chorionicity? So if you see a thin membrane, you do not see the double peak sign, then you're looking at a monochorionic diamniotic twin, right? So that is what we would potentially label this as. In the NT scan, what is the length of the normal nasal bone? So I already kind of mentioned this. So normally we do not measure the length of the nasal bone. As long as it's present, it's generally good enough. Can we measure so that's the next question. Can we measure the NT on TVS, and how do we do it? So ideally, we avoid measuring the nuchal lucency on TVS. And again, the reason for this is the criteria. Like I said, it's always better that we stick to a FMF or ICOG criteria. And if you look at the criteria, these criteria are actually on a transabdominal scan. So it's better that we do not measure this on the TV scan. If you do see a NT which is thickened, then yes, please go ahead, do a transvaginal scan. It will give you a better idea. It will give see, it will help you to see if there are any septations within nucleolucency. It will help you to even look at if there's any, of course, that would mean something like a cystic hygroma. You would want to see if there's any edema over the chest or the abdomen. So yes, do an NT, but ideally measure it when you're from a abdominal, transabdominal perspective. Another question is, can we measure the NT if the fetus is in a neutral position and is prone? No, because what happens is when the fetus is prone by gravity itself, right? I mean, whatever, the nucleolucency will actually fall down. So it's not ideal to kind of do this in the um, uh, in a prone position. What should be the ideal gestation for dual, triple, quadruple, and NIPT? So somewhere around 11 to 14 weeks is when we would do a dual. Triple, like I said, is redundant. Quadruple is something we would do between say 18 and about 21, 22 weeks. Again, that is becoming a little less popular because increasing awareness of the dual markers, which is good. So majority of the patients who come in for an NT scan are generally counseled about the dual marker. So if you do a dual marker and you do an NT scan, you do not really need a quadruple marker, right? And triple, like I said, has become obsolete. So quadruple would be maybe reserved only for those feti where nothing has been done in the first trimester. And NIPT, you can actually, that's very convenient because NIPT you can do anytime after about 10, 11 weeks, and it generally gives a good answer. So there's no restriction. So anytime after 10 or 11 weeks is good enough. Okay, I think there was some question on ductus venosus. So let me see if I can pull up my slides again. Normal values for beta HCG and Papa A, honestly, we don't really bother with the normal values. All the labs, when they send the reports, all these standardized FMF labs, they give you a risk. So rather than looking at the beta HCG and the Papa A, the actual values, it's best that we just look at the risk. If the risk is more than 1 in 250, and then yes, the risk is high. So anything which is like say 1 in 200 or 1 in maybe say 150, then you would qualify that as a high risk and subject this patient to further testing. Quad test, again, that's a quadruple marker, so it looks at a different set of enzymes. Like I said, yes, it can be done, but if you do a dual marker, you don't really need to repeat a quadruple marker. Mean uterine. So another question. Sorry, I'm just going over it quickly because I think there are quite a few questions. But is my speed okay, or should I slow down?
No, it's okay, Rajesh. Please, you can wrap up. That's fine.
Quite a few questions I can see popping up. Okay, so the other question over here is the mean UPI of uterine arteries can be normal even if one is high and one is normal. So how do we proceed? So again, what we're looking at is the mean PI. Okay, so don't look at the individual PIs. The mean PI is what we use to report. Right. So I already mentioned about the mean uterine PI in mom values. So there's a question on the mean uterine PI in mom values and what does it mean? Okay, so mom values. So I'm not sure about the mean uterine PI in mom values, but it is what we call as mom is multiples of median. So that is kind of another statistical way of analyzing this. So I need to check out of the uterine PI mom values. I don't know if that is particularly used. Uh, okay, there's another question. If one of the uterine artery shows high resistance, but the average PI is within normal range, do we mention in the report that one uterine is high resistance flow? No, we always mention in we always mention the mean uterine PI. Okay, criteria for megacystis. The next question, criteria for megacystis is 7 mm. Is it an absolute cutoff? Yes, technically, if you see, so again, when you're looking at 7 millimeters, what we are looking at is the superior inferior length, right? So yes, generally that is used as a cutoff, but see, what generally happens is, these cutoffs anyway, you have to take it with a little bit, with that pinch of salt. Now, for example, in a condition like megacystis, The moment you have a persistently distended bladder, the moment you see it, you will be able to identify it, right? And then, of course, you measure and say, you can say, okay, it's more than 7, and, it's definitely abnormal. Second thing is, a good number of times you may have back pressure changes, right? So you will see maybe